Today, I'm going to be talking about a medical emergency in rheumatology. Now, some colleagues who do perhaps more acute specialty work like emergency medicine or cardiology may smirk at the idea that rheumatologists have medical emergencies that must be attended to rapidly. Most of us have all done our medical training and will have been more than accustomed to having the bleep rush off to a cardiac arrest. So we're quite accustomed to what a real life-threatening emergency is. And although most rheumatological conditions don't need intervention at the point at which you're running to see the patient, there are some that can genuinely need intervention that if delayed by even minutes, can have an impact on long-term survivability and long-term morbidity, which is to say harm that comes from delay. One of the key ones in this area would be a hot, swollen joint that has arisen from an infection. We call that a septic arthritis or infectious arthritis. The joint space is quite a unique space in that it has fluid, a lubricating fluid, like a human oil, if you'd like, within the joint space that allows for low friction movement between the two surfaces, which is usually two bones covered in a nice shiny cartilage to, again, help that low friction movement. But it is a warm space, it has nutrients, it does not have good blood supply, and so if a bug is able to get into that joint space, it has a ready supply of food and nutrients in a warmed environment, which is not easily accessible to our body's defense systems. For that reason, when the infection takes rise, it can multiply and release toxins in a very rapid sense, whilst the immune system is pretty hampered to enter that space and destroy that invading organism. So why would you get an infected joint? Well, the most obvious would be, has someone done something to the joint itself? So have we as doctors caused what's called iatrogenic harm? Have we done something like stuck a needle in or done a joint replacement? Obviously, this is not intentional harm, but any procedure that we do, anytime we put instruments in, anytime we put prosthesis in, we are changing the natural environment. We are opening the potential for bacteria, many of which live comfortably on our skin without causing us problems, to be introduced into this confined space. So recent injections, recent procedures, recent camera tests, anything that's breached that barrier could cause an infection. The other group of people are those at the extremes of age. So if you are very old or if you are a child, you have a significantly increased risk of infections getting into the joint. And actually, if you're very young, it's particularly risky. You could argue if you're very old as well, if you have communication difficulties. So if you're very old and perhaps have Alzheimer's or dementia, very young and aren't able to communicate, you could see how a hot swollen joint may just cause increased irritability or increased confusion without being able to communicate clearly why that has arisen. If you have underlying health complaints, in particular diabetes is a major risk for developing a joint infection, but anything that suppresses your immune system significantly. And you could argue that some of the more potent medications that rheumatologists use, especially things like high doses of steroids, they also increase your risk of infection because they dampen down your immune response. Sometimes other illnesses, long-term illnesses like kidney diseases, poor circulation, these all can increase your risk. Okay, so what is likely to be your presenting complaint? Well, you're going to have a painful joint. The level of pain is not linked to the amount of risk towards infection. So people often characterize a septic joint as exquisitely painful, but in clinical practice, I can tell you I have seen people with very painful joints coming from things like gout, and people with relatively modest pain coming from things like infections, especially if you have diabetes, where some of the nerve fibers may have stopped functioning correctly, and you may not be experiencing the level of pain you maybe should be because of the impairment in the nerve supply to that joint. The joint is usually warm, the joint is usually swollen, the joint may be red. Those are the kinds of features to look out for. You may also have signs of what's called a systemic infection, so a high temperature, feeling flu-like or under the weather, shivering or shaking, vomiting, or any other feature of an infection with the toxins that go with it. Okay, so we know what it is and how to pick it up clinically. Why is this such an emergency? Well, we've talked about how we can't fight it very effectively. So because the bacteria can spread, they can produce toxins. Those toxins could interfere with the way we regulate our blood pressure, and that can lead to toxic shock. These toxins can make our blood vessels go floppy, and it makes it very hard for our bodies to adequately deliver the blood pressure that we need. So lots of different names for that, and septicemia, which is where you get bugs into the bloodstream and they're producing toxins that affect our blood pressure. The toxins themselves are capable of causing destructive damage to the cartilage, some more than others. But with the most aggressive forms, it's possible that you could have more than half of the cartilage completely destroyed within a 24-hour period. So leaving this untreated may result in a very damaged joint in a very short space of time, potentially even meaning you had to have a joint replacement as the ultimate outcome. So risk to life, risk to joint. How are we going to investigate this? There is only one test that really must be done, and sadly it's often overlooked. That is to stick a needle into the joint, to suck some fluid out, to put it under a microscope. It has to be done early and ideally before any antibiotics. That way, you should be able to see the microorganism under the microscope and have a good chance at growing the microorganism in a culture. By growing the specific microorganism, we can identify what it is, and by knowing what it is, we can choose the right targeted antibiotic to kill it. If we don't know what it is, we have to choose a broader antibiotic, potentially for a longer period of time. And often, when people come to hospital with a high fever, for good reason, we're very quick to give antibiotics and give treatment, and not perhaps as quick as we should be in taking fluid from the infected joint. Unfortunately, even a single dose of antibiotics might limit the chance of getting good, meaningful results from the joint aspirate. There's often a perception that we can work out whether this is an infection based upon other markers. Oh, the fever's not high enough, blood markers of inflammation aren't high enough, the pain isn't enough. My experience, and that of many of my colleagues, is that none of these markers are particularly helpful. And anyone who has what's called a monoarthritis, that is a new single joint that has become hot, red, and swollen, your first thought must always be, could this be infection? And should I be doing an aspirate? And once you've answered that question, everything else is secondary. Things like blood tests for blood count markers, looking at white cells, inflammatory markers, and a blood culture to see if any bacteria are in the bloodstream are also helpful. Treatment, well, you can wash the knee joint out, you can give antibiotics, and sometimes surgery is needed. So I hope that's helpful in understanding one of the emergencies that we have in rheumatology, the acute hot joint, particularly in ruling out a septic arthritis. Leave me some comments below, and if you've enjoyed the video, give it a like or a subscribe to the channel. Thank you.